Welcome to this BTOG podcast. My name is Tom Newsom-Davis and I'm a medical oncologist at Chelsea and Westminster Hospital in London. I'm Vice Chair of the BTOG Steering Committee. I hope by now that you know that this is part of our regular podcast series entitled BTOG Does, where we have informal chats with experts in their field and we tackle the most important questions that we all face in the diagnosis and the treatment of thoracic cancers. It's important to say that the sponsors of BTOG do not in any way have any input to the planning, content, or delivery of anything that we discuss.
Welcome to another BTOG podcast. This podcast is continuing our theme about mutations in lung cancer. And I thought that this month we would talk about KRAS. And if you're going to talk about KRAS, you really want only one person in the UK talking to you. And luckily enough, he's joining me for the podcast. And that is Colin Lindsay, who is Mr. KRAS. And they're more exciting titles than Mr. KRAS, but I think it's a very important one. Colin is a senior lecturer and honorary consultant in medical oncology at the Christie, has an active research portfolio looking at KRAS-centered things, as well as, of course, being an oncologist specializing in thoracic malignancy. Colin, welcome to our podcast, Mr. KRAS.
It's a very kind introduction, I think, Tom. Thanks very much for inviting me.
That is my great pleasure. We are recording this at the beginning of September during the heat wave. So Colin's in Manchester looking hot and I'm in London looking hot. We're going to focus, as I say, on KRAS. And I think most people listening to the podcast will be more aware of KRAS now than they have been perhaps for a long time, because we've now got things we can do about KRAS. But Colin, I'm going to go back to the biology of it. And I wonder if you could tell us what KRAS is, where is it, and what does it do?
Yeah, of course. And so for me, I do love talking about KRAS. So hopefully I can, show you that today, Tom. It's the most commonly mutated oncogene in cancer, I think, is the first thing always to say, and it's the most commonly mutated oncogene in lung cancer as well. And so as with a lot of these targets that we discuss, it does dominate adenocarcinoma in particular. In lung cancer, it's mutated in about 30 to 40% of adenocarcinomas with point mutations that I'm sure we'll come onto. But in terms of the cancer cell, I mean, it really, from my point of view, sits at this really crucial junction whereby it connects the signaling of all the receptor tyrosine kinases that we talk about, such as EGFR, such as HER2, and then transduces those signals from the receptor tyrosine kinases down to the cancer pathways we always talk about, such as the MAP kinase pathway, such as the PI3 kinase pathway, that make the cancer cell do the things that it likes to do, such as proliferate, evade immune signals, evade death signals, those sort of things. And so, I mean, one thing that I keep coming back to more recently that I think people might neglect to think about is there is a reason that we've known about KRAS since the beginning, and that it's mutated in so many cancers, and that's because it is so effective, and so we really need to find good ways to target it.
And we've known about KRAS mutations for a long time, haven't we? We've known they're fundamental to cancer. I remember this when I was a medical student, I think. Why has it taken so long for us to actually get a treatment that works?
Yeah, and I mean, there's inevitable comparisons with kinases, and that can help with this. There's an immediate comparison with BRAF, which is the kinase immediately downstream to RAS, as you know, and I think with BRAF, it was discovered to be mutated by the Sanger about 2002, and within 8 or 9 years, we had drugs that were kinase inhibitors hitting BRAF and melanoma.
Yeah.
But the difficulty with RAS, I mean, I think it was discovered as an oncogene in the early 80s, is that it's a different type of enzyme, essentially. So kinases bind to ATP, but RAS is something known as a GTPase, not a kinase, and a GTPase is bind much more tightly to their substrate GTP than kinases bind to ATP. So it's very difficult to find drugs to interfere with that interaction.
So it's at a molecular level that we've struggled. It's not that we don't know it's a problem. It's not that we don't know what we want to do. It's just it's difficult to get drugs with the effectiveness that we want. Unlike EGFR, where actually finding kinase inhibitors has been comparatively straightforward.
Yeah, that's right. It was never going to be a target susceptible to big screening programs, for instance, looking for promiscuous inhibitors. I think it's really required X-ray crystallography expertise. I think it has required academia and people who've been prepared to take a very long approach for our most important targets. And it's ultimately led to really a proliferation of X-ray crystal structures for a number of different mutants that have been described across the world now. I'm sure we'll come on to it, but there's going to be drugs for different RAS mutants.
I want to ask you about that, but I'm going to keep that for our third course.
Maybe I should just finish just because it's an important thing to say is it is a very small, smooth protein. So it is as simple as just thinking about drugs hanging on to pockets, and there wasn't an obvious pocket for a drug to hang on to with RAS until we had those structures.
Interesting. You touched upon the fact it's the most common oncogene in cancer. I only treat lung cancer. Which of our other colleagues, other tumor sites, are frequently seeing KRAS mutations which have clinical or therapeutic significance?
Yeah, I mean, I guess I would broadly bracket cancers affected. The main cancers affected by RAS mutation as recalcitrant epithelial cancers, and so they would be the main one actually that's affected by KRAS mutation is pancreatic, and that's in over 90% of cases. Lung obviously is as with pancreas, they are the two key cancers that we want to do much better with. But even with colorectal cancer, I think it's fair to see that progress isn't as good as we would necessarily like. I think it's still about a 50% mortality, and RAS is mutated in about 40 to 50% of colorectal cancers. Now, there are different isoforms or flavors of RAS, if you like, and so those are the main ones affected by KRAS, but less commonly we have NRAS mutated in cancer, and that's very frequent to melanoma. And then we have an even rarer subtype called HRAS, which is actually making precision medicine inroads, and that is common a little bit to head and neck and bladder cancer.
So these are just to touch on that a little bit for people whose molecular biology won't be quite as expert as yours. When you talk about different isoforms and you're talking about KRAS and NRAS, how are they different? Is this the same molecule which is slightly different, or is this a different molecule and a different part of a pathway?
Yeah, that's a good question. It could lead to a more complicated answer, so I'm just trying to think of how to keep it simple.
Keep it simple for me.
In actual fact, the way the proteins look between KRAS and NRAS and HRAS is very, very similar. The main differences in those sort of amino acids that make up the protein is that the hypervariable region, which inserts into the plasma membrane where RAS becomes active. Sorry, it's a complicated answer, but they're ultimately very, very similar, but have differences that are enough to make fundamental differences in what we see in terms of mutation patterns and probably clinical phenotype in terms of the way different cancers behave.
Got you. So we're going to focus on KRAS because KRAS is of relevance to us in lung cancer. The main thing we're interested in KRAS are mutations. We're not interested in fusions, just to explain to people. We know there's more than one mutation. We know, as I suspect most people listening will know, that G12C is the one we're particularly interested in at the moment because we have drugs against it. But could you just tell us, when we say G12C, what do we mean by that? And what other mutations or abnormalities of KRAS are we seeing which are relevant to our patients and their treatments?
Yeah, so G12C is a point mutation common to lung cancer, as you said, where a glycine is swapped for a cysteine, and that's enough to change the protein so that it binds more, we imagine, more frequently to the effectors in the MAP kinase pathway and the PI3 kinase pathway that I mentioned earlier. So G12C, just to break it down, I said the RAS mutation is about 30 to 40% of lung adenocarcinoma. G12C would be about 40 to 45% of those RAS mutations. And what that amounts to when we're on the ground in the clinic is, I think we said it's roughly 13% of adenocarcinomas that will have the G12C mutation. So somewhere, I think, for most of us, similar to the rate of EGFR mutation, for instance. What is interesting is that the point mutations are relatively predictable, but different point mutations occur in different cancers. Actually, G12C, but through luck for us as oncologists, is the one that's targetable, and it's also most common in lung cancer. But it's not so common in the other cancers I've mentioned. So the two most common KRAS point mutations in cancer are G12D followed by G12V, and they're particularly prevalent in colorectal and pancreas cancer. And so, obviously in terms of drug discovery, using the principles of what has been achieved so far with G12C inhibitors, we're trying to see if those principles of drug discovery are transferable now to G12D and maybe to G12V in the future as well.
That's very helpful. And when colleagues are looking at their molecular pathology results, it's of course very important to make sure that when you see KRAS, you look very carefully at the subtype, because there's no point throwing around a G12C targeting drug if that's not the mutation that's present. Who gets KRAS G12C particularly mutations? And let's focus on G12C from here on, pretty much, if that's okay. I see quite a lot of it in my patient cohort. I had often thought it was perhaps more associated with smoking, but I happened to see someone on Tuesday who's got G12C mutation who's never smoked. Are there clear patient demographic guides as to who have these mutations?
Yeah, so we've talked about adenocarcinomas, and so there seems to be a slight dominance by females as opposed to males who will have KRAS mutations. Don't know about you, but I'm never quite sure if that's maybe just because we maybe test more females, but certainly that's a common thing that we find.
Sorry, so more common in women than men.
Yeah, sorry, yeah. I guess the other thing that is a critical difference to the other targets we've talked about in the past is a smoking-related mutation, as you've alluded to. And so I must admit, I can't remember the last time I saw another smoker with G12C, but I'm pretty sure I will have done in the past. It immediately obviously makes you think about passive smoking possibilities. I'm sure you would have asked about that, but it does feel like there are just genuine exceptions.
Yeah. So generally, this is a smoking-associated, non-squamous mutation that we're seeing. With the other KRAS mutations, just very briefly, you touched upon G12D, G12V, and the others beyond that. Are some of those more common in non-smokers, or is KRAS largely the smoking lung cancer kind of mutation?
Yeah, I mean, for the latter part of the question, the answer is yes. It's largely a smoking-related mutation, but in terms of the nuance, I think it is interesting because you can see clear smoking imprints in terms of the DNA changes that occur, and the ones that kind of correspond well with a smoking imprint are all of them, apart from the one I mentioned earlier as being the most common, which is G12D. And so, I mean, at least in our hands, and I think in everyone's hands, there are more never smokers that might have KRAS G12D. But I think an important addendum to that is that most of our G12D cancers are still smokers or ex-smokers. It's just the higher it's just a higher proportion.
I've certainly seen that. I've certainly seen where you're doing your molecular analysis, you're hoping for the EGFR, the ALK in the non-smoking patient, you get a KRAS, and it's a G12D is one I've most commonly been very disappointed to see. Just touching very briefly before we move on to the G12C inhibitors, what's the best way of detecting a KRAS mutation?
Well, I mean, I think this is probably an answer for different centres. It's definitely, I mean, for bigger centres, it's probably NGS. I think it's reasonable to just sort of do single gene PCR still for KRAS. You know, we are, as you well know, getting smaller and smaller biopsies and samples from patients when they're diagnosed, and so there's always this question that I'm never sure we quite nail about how to prioritize your gene tests. But certainly PCR and NGS are the main ways of diagnosing KRAS mutant lung cancer.
And is there any concern, as we do have with, for example, EGFR, that a PCR-based assay is going to miss types of KRAS, or if colleagues are listening and all they have is a PCR-based system, they don't have access to next generation sequencing, can they be reassured that they'll pick up all they need to in terms of KRAS?
I mean, I think it's fine in my experience, at least. I haven't heard of any controversy with that. It's a hot spot, and I think it should be picked up with PCR.
Brilliant. So we're going to move on to the G12C inhibitors. These have been hitting the headlines since 2018. I remember being in ESMO in Barcelona, or maybe it was 2019. It was certainly before COVID. So it feels like a million years ago, when Sotorasib, which then had just a code name, the phase 1 data was being released. Since then, we've had more data, the code break studies. Can you just give us a bit of an outline on Sotorasib and I guess its clinical activity? And before you do that, I'm just going to say to people that Sotorasib is not a tyrosine kinase inhibitor. So a lot of people think it's not a lot of people may think that, for example, it's a bit like osimertinib because it ends in ib, but these are actually very distinct drugs. It's not a TKI, and so we should see the activity differently. Having said that, what's your take on the clinical data of the code-break studies?
Yeah, thanks for that, for mentioning that. I think yeah, it's a different drug, and arguably it's a different disease as well. And I'll just probably briefly digress a little bit by saying when I started this job in 2017, I'm pretty sure that I went to one or two meetings such as World Lung, and RAS just wasn't mentioned at all. I mean, that was a completely unimaginable prospect now with any of the meetings we go to. But coming back to the point, CodeBreak has kind of trailblazed with this drug Sotorasib. And what happens is the chemical structure gets disclosed for the academic drug that was first described, and then companies, produce their own variations of that drug. And so Sotorasib was first in the scene in clinical trials and has generally led publications at phase 1, phase 2, and now phase 3. I was involved in particular with CodeBreak 200, which is the only KRAS inhibitor in lung cancer to get to phase 3 at this point. And what that did was it compared in second-line KRAS G12C mutated non-small cell lung cancer Sotorasib monotherapy with docetaxel. And so I'm pretty sure what you're driving at, and I will come to it, is how impressive the results were or otherwise. But just for the benefit of people listening or watching, probably the most impressive way of describing the results is at 1 year, I think 25% of patients were alive with Sotorasib and about 10% with docetaxel. Some of the top line data doesn't sound so impressive when you offer it in other ways, such as a response rate of 20%, which was probably originally described more in the high 30s at phase 1 and phase 2 level. And I think from memory, the median PFS was something like 6.5 months with sotorasib compared to 5.6 months with docetaxel. So if you look at it in those terms, then it was just a 1 month gain, and of course that would have been the primary endpoint. Overall survival as a primary endpoint was ultimately abandoned due to an FDA mandate. So I don't think we can say much more about that.
And let's just touch that because it's really important. So they changed the outcome measures, didn't they? Well, so the endpoints. What that was done by the FDA, the American Regulatory Authority. Do we know why that was done? Because it's had an impact on how we can interpret the data, hasn't it?
I think it was a decision off the back of its success at phase 1 and phase 2. They were like, this is a drug that's clearly showing activity, and so we want you to complete this phase 3 trial as quickly as possible, reduce your recruitment numbers, because I think they cut about a couple of hundred of patients off the planned recruitment, and just choose the most straightforward endpoint. And so, I mean, you could probably talk for a while and speculate about the rights and wrongs of that, but I mean, I tend not to, if I'm being honest. I think, we've had these debates with TKIs in the past. And I think what we see in the ground, I'd be interested to see what you think, is benefits with this drug. And some patients are a better fit for it than others, possibly still.
And I guess we have to look at that benefit in isolation of it being a KRAS inhibitor. We shouldn't go into it expecting an EGFR or an ALK TKI type response, because it's a different cancer, it's a different disease, it's a different drug. And I guess in that respect, we say, yes, it's clearly active. I think the lack of that overall survival benefit was disappointing, but I think it is important we see it in the broader context of a trial where the endpoint was changed and it was underpowered for OS in the end.
I mean, I think a few people have probably thought quite hard about all the differences compared to what you might expect with a TKI, and there's both clinical and biological reasons why it might not perform as well. We've mentioned one or two already, but I guess the first thing to say in terms of clinical reasons is that we've not seen these drugs in the first line yet, where probably TKIs have the best efficacy. We've just seen pre-treated patients so far. The sort of and the other thing to say is that we've seen second and third generations of TKIs that have really raised their game compared to the first generation of TKIs that we saw, and I think we can anticipate that will be the case with RAS inhibitors as well. The biological reasons that I think are harder to address and may well mean that these drugs still don't quite reach that level that TKIs are producing success are, for instance, that we're treating smoking-related lung cancer. You can imagine with all those mutations built up, the potential for resistance and the tumor mutation burden is quite vast in smoking-related lung cancer. And the other thing, coming back to what I said at the beginning, is that RAS isn't a receptor tyrosine kinase. It is in the middle of a pathway, although a key node in the middle of a pathway, so there's probably more potential for signaling bypass and things like that as well.
So I guess I agree with all of that, and I guess my take is I think it has activity. I think it is clinically significant activity. In the big scale of all of our treatments, I think we would probably say it's modest, but as you say, it's a first step. Let's think a little bit about side effects. In your experience, you've got a lot of experience with this drug. What are you seeing in terms of side effects of sotorasib, and what are your practical steps if people do develop side effects?
Yeah, I guess I'll probably deal with the sort of second worry first, because often we're so I try and preclude the second worry, which is transaminase rise, liver problems, by if I can, waiting for as long as possible before I move on to sotorasib as a treatment after someone's had immunotherapy. So maybe as a standard practice, I would probably update a scan 3 months later if I think the patient has time to wait, because we know that potentiation of liver toxicity by KRAS inhibitors and TKIs probably is more likely the closer you are to dosing them, the two things together in time. And so if I can, I'll wait 3 months to try and prevent liver toxicity, which I think in COBRA was described at grade 3 level at about roughly 5 to 10% of patients. The other key thing is diarrhea and gastrointestinal upset. And I think at grade 3 level, that was described at roughly 10 to 15% with sotorasib, and Imodium is certainly helpful for that. But it's unquestionably a problematic side effect in some patients. And I guess one of the interests with that is really going back to the phase 1, actually lower doses of sotorasib were quite effective. And the FDA also mandated, and I don't know where this trial is, this sort of phase 2 trial comparing 2 different doses of sotorasib. And so it may be that we reconsider doses in the future, but overall what it amounted to was about 30% rate of grade 3 side effects, mainly constituted by diarrhea and liver derangement.
And I think it's fair to say, and I agree that those are very much the side effects one sees, that prompt recognition, holding a dose, and then either restarting or dose reducing is key, and not to be shy of dose reducing, because I found dose reductions can be very effective in management of side effects. And GI side effects are not very nice. I mean, although we would say, ironically, a grade 2 diarrhea is mild, if you've got grade 2 diarrhea, it's not mild, it's miserable. So I think we should say to our colleagues, watch those symptoms. I really like the idea of, if you can, separating the immuno from the KRAS inhibitor, and we'll touch on that in a minute or two. But yeah, dose reduce if you have to. And dose reductions in the trials were not inconsiderable.
No, and actually I don't have the number of this off the top of my head. I'm sorry.
Yeah, neither do I, which is why I said not inconsiderable.
Yeah, I mean, I think I'm never shy with dose reduction. It's impossible to say ultimately, so it's probably not worth speculating on that. I'm never particularly convinced that it affects clinical outcome when I dose reduce targeted therapies in general, but certainly with the KRAS inhibitors.
There are other kids on the block. They're not currently funded or available in the NHS. Adagrasib, or however you want to pronounce it, is the other one. It came out very, very similar time, probably a step or two behind sotorasib, producing very, very similar data in terms of response rate, progression-free survival. But they did have some data on brain activity. What's your thought on adagrasib generally? Is it a better drug, the same drug? And what's your view on it regarding brain activity?
Yeah, thanks. I think it's really interesting to have the comparisons. I think the top line data, as you've suggested, is very, very similar. Where we are, maybe I'll start in what we call it, because I am pronouncing it differently, I think, to our American colleagues who say sotorasib and adagrasib, but those are very hard inflections. I think it trips off the tongue to say adagrasib. The top line data was for what we have with adagrasib, which is Crystal 1, a phase 2 single arm study, is a median overall survival, which is very similar, 12.5 months. A response rate, which was very similar to at least the phase 2 for sotorasib, which is in the high 30% region, and a median PFS, which I think is around 6.5 months as well, very similar too. What is quite interesting when you look at the detail of it is the waterfall plot is unquestionably more impressive. You see more depth of response being apparent, but there is probably a higher toxicity rate with adagrasib as well. So I don't know necessarily if it's just you're gaining one thing and losing another, and that's why the top line data is the same. But there is a bit of a sense of that. because adagrasib has been slightly behind sotorasib in clinical rollout, as you might imagine, they're trying to show things that are exceptional. You know, the Mirati is trying to show what's exceptional about adagrasib, and so they were definitely the first to describe, off the back of some preclinical data, some CNS efficacy. But these are small molecules. I have to say, I think I expected them to both offer CNS efficacy, and actually the data I have to hand is really the one I was involved with more, which was the cold break stuff, which showed ultimately the time to CNS progression in patients with brain mets, and in code break was 6 months for docetaxel to near 12 months for sotorasib. And so there seems to be, although Mirati were the first to describe this, undoubtedly, I think there seems to be CNS efficacy for both, probably what we would expect. Very important for our patients, incredibly important for our patients. Also just slightly difficult, at least as far as I can see, to unravel how much of it was previous radiotherapy, how many of these lesions were untreated, but unquestionably some of them were untreated with radiotherapy before and seemed to be responding.
Yeah, absolutely. Okay, that I guess is less relevant at the moment because we don't have access to drug, although it may do. In the last 3-4 minutes, I wonder if you could touch on what's next, because you mentioned, and I would be in agreement, that the data for SOTO and ADI, that's much easier, abbreviations. It's good. It was great to have agents. KRAS is a common mutation. We are very grateful for drugs that work at all. But it is a first step, and I think the activity is modest. What is being done to try to beef this up? Now, I'm aware that there was data of combining SOTO with immunotherapy, which created a lot of toxicity, hepatotoxicity, and that study was stopped fairly quickly. But then there is data on ADI at a lower dose with immunotherapy, which seemed to get rid of that hepatic toxicity. What's your take on that? And what other approaches beyond sticking in immunotherapy do you think might bear fruit for the G12C patient population?
Yeah. I think the first thing that's really interesting, of course, is that because this is a target in smoking-related cancer, immunotherapy combination absolutely comes to the fore in a way that it never did for TKIs. It wasn't particularly successful with TKIs, but it wasn't such an important question to answer because we didn't necessarily see immunotherapy would offer so much to never smoking patients. Now, for KRAS inhibitors to really leverage their success, I do think we need to see immunotherapy combination occur successfully in some way or another. So the data, I think, started with sotorasib again, and as you've said and described, I think the combination was looked at in different ways in a phase 2. I think it was looked at with atezolizumab and pembrolizumab and different doses of sotorasib. And whatever way they looked at it, they were seeing high rates of grade 3 liver toxicity. And so this has sparked something which is going to be interesting for the future, which is, as far as I can see, the sotorasib ongoing combination trial program is dropping immunotherapy and prioritizing chemo combination with sotorasib compared to chemoimmunotherapy. And that is a clear divergence from what Mirati are doing with adagrasib. So adagrasib, I think, have clearly described very interesting efficacy. Has clearly described very interesting efficacy with immunotherapy combination. It seems to be a bit PD-L1 dependent for whatever reason, but from memory at AACR this year, they were talking about response rates up to 80% in PD-L1 high disease with adagrasib combination. Now, I think we need to see more data about the toxicity with that, because clearly the line was that there was less liver toxicity, but to me it did still look like there was significant rates of grade 3 toxicity. I just wasn't totally sure on what that toxicity was. But I think the top line number was still something significant, like 30–40%, Tom. And so, obviously, as you know, sometimes it depends what the toxicity is. And obviously, Mirati have decided they're going to go for it, and I commend them for that. I think we need to really push with this question and find a way for our patients how to combine the two. But I don't think it's necessarily all going to be straightforward. I presumed, and I think I may be wrong with this, that it would all just be like a class effect that's common to all G12C inhibitors, but then there is data from other companies suggesting that the dose of G12C inhibitors can make a difference, and they're seeing less immune-mediated toxicity with a lower dose of their G12C inhibitor. So I'm not quite sure. I haven't figured out all of my thinking in this, but it's just a tremendously important question.
But I think it's also good for our patients that we have two companies looking at different combinations. They're both doing the same thing. Then your options are more limited. So we look forward to that. SHP2, SHP2 inhibitors, they've been bandied around as something to add in. Are you excited by that, or do we just need to wait and see what that throws out?
I think they're very interesting drugs. I think their place. I mean, if we talk a little bit about the science, basically SHP2 mediates some of the activity of RAS, so RAS cycles between being off and on, and SHP2 kind of mediates, it prompts it into being in more of an on position more frequently. And so you could probably intimate from that its role is, I think, is going to be more of an adjunct to the RAS inhibitors, and I don't think its monotherapy data has been particularly impressive from what I've seen. There have been data from a company, for instance, we've been involved with called Revolution Medicine, who produced the SHP2 inhibitor, and they have their own RAS inhibitors, but initially they combined it with sotorasib, and so we're going to see some more data with that. But I think the role of drugs such as SHP2 or SOS1 inhibitors is going to be more combinatorial.
Interesting. Last question. Brief 30-second answer. I get asked a lot about from patients and colleagues about patients with non-G12C mutations. Obviously, there's nothing licensed at the moment. If you were to give your top one or two potential approaches to those, what would be your top one or two, or do we not know yet?
So my top one or two potential approaches to G12.
Non-G12C KRAS mutations. Do we have classes of drugs which are beginning to be looked at in early phase trials? Are we still really nowhere near these guys?
Okay, yeah, I think I hear you. I mean, it's probably monthly, if not weekly, where I have colleagues asking me when a G12D inhibitor is going to come.
You need to work harder.
Yeah. I mean, the answer is, and it's, I think it's great news, is that G12D inhibitors are in clinical trials, not G12V inhibitors, which may be covered, or which may be addressable in the future, but there are pan-RAS and pan-KRAS inhibitors that are coming through that may address G12V. But coming back to G12D, those drugs are in early phase clinical trials, not in the UK, and I think just in the US at the moment, and that's for the simple reason, unfortunately, that it's US-based companies that are creating those drugs, and it's a finite number of patients in need for early phase trials, and those patients can come from the States. But I do speak to these companies on a fairly regular basis and really try and plant the seed that we have such an emotion, such a need for these, if they're going to be as effective as G12C inhibitors. I think that's enough. I think to really encourage them as quickly as possible to bring their trials to the UK.
Yeah,
if not pan-RAS, pan-KRAS. I think I probably do need to be working harder, because I'm not succeeding so far in getting one of those trials here, but I promise it is really top of my priority list whenever I go to clinical meetings.
Colin, yeah, I think that kind of advocacy for our patients and trying to bring studies to the UK is incredibly important, and I think it's not seen by people. So we commend you for your efforts. It's hard. We all want to make the UK a better and more attractive place for trials because that's better for our patients. But it can be hard to fight against the bigger countries sometimes.
Yeah, and just I hope you don't mind me digressing a little bit to this, but the science of G12D is a really important one, and it does make you think that G12D inhibitors could be more effective than G12C inhibitors, for example, because it really seems to be a bit more of an oncopotent mutation than G12C. So if you can get a drug that hits G12D in some sort of similar way to G12C inhibitors and G12C, I think it could work very nicely.
I will leave it there. Colin, that was a tour de force. Thank you so much. I can't imagine anyone knowing more about it than you. I now know more about it than I did. So I'd like to thank you very much for your time in this podcast. Just to remind people listening that you can get various other podcasts through where you download them from. And we're going to be continuing our program of other mutations. And in the next couple of weeks, we are also recording a podcast away from mutations, this time something completely different about the GIRFT, or the Get It Right First Time external review of cancer services, which is something we've probably all been through, and which is an important thing to make sure that we are maintaining good services. So Colin, thank you very much, and thank you very much for everyone for listening.
Thanks, Tom.